Hello, everyone. First, I want to congratulate the entire team, Ben, Daphne, and Tom, for creating this amazing platform and amazing conference. So much to learn and so much to interact with, so thank you. I want to start by sort of sharing a story. So I was a first-year fellow at Boston Children's in 2001, and this gentleman in the middle, or this boy in the middle, who has a tracheostomy, as you can see, he's on a wheelchair and has oxygen, was a baby then when I was a fellow and was born there and was transferred from a delivery unit. And the baby was not moving at all, was diagnosed with hypoxic ischemic encephalopathy, as we always do. And it took us almost 3 to 4 months to finally say that this child has a genetic condition called myotubular myopathy. I don't know how many of you have heard of this term. This is one of these extremely rare conditions, 1 in 50,000 boys, because it's an X-linked condition. But this really sort of made me think that why are we are at Boston Children's, supposedly one of the top hospitals, and why it took us so much time to really get to the diagnosis. And that sort of piqued my interest, and I looked around and found a lab that was working on myopathies. And in fact, we enrolled him in our study. So I worked in the lab for many years. But meanwhile, I realized that it's just not these myopathies, but we are facing these type of patients all the time in the NICU, especially at a tertiary center like Boston Children's. So in 2009, we built a center called Manton Center for Orphan Disease Research with the goal of helping these families who have kids or babies with an undiagnosed condition. This was funded by Manton family. They gave us $25 million. Fantastic startup for us to get this going. And as I moved forward in 2000, we started to use exome and genome sequencing in our research. But then in 2010, clinical exome was the first paper published in Nature Genetics. And then in 2012, there was evidence of rapid genome sequencing in the NICU as a way to help these families with an undiagnosed condition. So in today's talk, I'm going to touch base on some of those topics. I'm going to talk about rapid genome or exome sequencing, role of molecular autopsy in the NICU, and then how can we implement genomics in resource-poor NICUs. We'll also talk about a very controversial area right now. What is the role of sequencing in healthy newborns? Then I'll talk a little bit about research opportunities, and then a case of a therapeutic development. So as I said, in 2012, I think the first paper was published on rapid genome sequencing from Rady Children's by Stephen Kingsmore Group, some of you may know. And we did our own study at Boston Children's where we tried to test this hypothesis that if we come up with a list of diagnoses, like a baby who's born with hypotonia or born with unexplained seizures or with multiple anomalies or a complex metabolic disorder, or some of those phenotypes we came up with a list, and then we did rapid exome sequencing on the trios. And in this study, we reported a diagnostic rate of 60%. So we enrolled 50 babies, and we were able to find a diagnosis for them in 30 of them. So that was pretty amazing. And then we also found that a lot of people, I've heard from many neonatologists, okay, you have a name for the condition, right? You can call it this X gene caused this condition, but does it really help the families? And I want to say that it helps these families in so many ways that we don't understand till we face it. So for example, one of these patients had a SCN2A mutation, which is a sodium channelopathy, and this child came from Philadelphia for a second opinion because the child had persistent seizures, and they were trying all the medications, nothing was working. And they had done a gene panel, and they found 3 different genes that were mutated in this patient. We enrolled the patient, and we found one of them, in fact, was the de novo mutation, which is SCN2A, and based on that, we started this patient on phenytoin, and the seizures were much better controlled after we started this treatment. Similarly, there was another patient with MTM1 mutation that was eligible for a gene therapy trial. But in addition to all this, we had several cases where based on the genetic diagnosis, we sent them to a different specialist. Like, for example, there was one patient where we sent to endocrinologist based on the fact that this gene is known to cause endocrine issues. It also helped a lot of families with reproductive decision making in the future. And several of these hypertonic kids, for example, we could make a quick decision that this child needs trach and G-tube. And then in one case, we found that in a patient who had apnea and very subtle findings which did not fit into anything, once we found that this child in fact had Lesch-Nyhan syndrome, the family decided to redirect care, and this child went through early comfort care. So this is if those who know about Lesch-Nyhan, it's one of the worst diagnoses. The patients undergo self-mutilation, severe developmental delay, and lots of issues. So this family, appropriately so, decided to go for early comfort care. So there's so many different implications when you get a molecular diagnosis for these patients. So I want to tell you another story. So this is a baby I was on a Sunday morning. I came to the NICU, and this baby comes in, and the child is seizing and looked devastated, put on EEG monitoring, really bad seizures, did MRI, really bad MRI, brain was completely, it was absolutely damaged. And then when we look back, this child was sent home 2 days back from level 3 NICU adjacent to us. And this child was born, normal vaginal delivery, full-term baby, was doing fine, except that we had some subtle, some periodic breathing, and did not look right. And then they also failed hearing screen. So they did a complete evaluation. They did microarray, they did MRI. MRI showed some small lactate peak. But at the end of the day, they felt that the child was stable enough to go home on a monitor and started on caffeine, and child improved on that. So there was no diagnosis, basically. The child went home. But 2 days later was admitted to our unit. Anyway, long story short, the child was enrolled in our study, this rapid exome sequencing. We found the child had, in fact, 2 variants in a gene called HIBCH, which is one of the genes involved in Wallin catabolism. So when we looked at the data, there was one VUS. I don't know if you have heard of variant of unknown significance. And there was a lot of discrepancy between clinician from metabolic team and us, whether this is truly the diagnosis or this is just a red herring and the child is something else. Lucky for us, we had saved a sample of skin biopsy from the child, and we had grown the cells, and we sent those fibroblasts to a lab in Europe who was doing this evaluation of HIBCH activity, and we found that the child was indeed deficient in HIBCH activity. So we confirmed the diagnosis, but this family was decided to sort of take this as one of their, they really wanted to help more families like theirs to raise money and support our research. So this is a family that have already raised close to $500,000 for our research, and they continue to do that, and they're very involved. And I just wanted to say that for us, a lot of times when a baby dies, we just say, story closed, but for many families, it's very important that we get to the bottom of the cause so that it can really help them. And now they have three kids who are all doing fine and who were born by pre-implantation genetic diagnosis. And it has been a great story. So the other thing which I'm sure you noticed that many centers in the US have the ability to do genome sequencing, but a majority of them still don't have the opportunity or don't have the resources or don't have the desire in sometimes to really use this technology in their babies. So we implemented this study, which is Virtual Genome Center for Infant Health, where we are enrolling babies from these 10 NICUs across Massachusetts, New Jersey, Alabama, Florida, and Texas. And then this is a proof of concept implementation study. And this is a study funded by the NIH. So what are our goals? We want to build a center, which is VIGOR, or Virtual Genome Center for Infant Health. And we want to enroll 250 babies. We want to do not only facilitate sequencing, but also create a report for them. So a lot of times, there's a lot of jargon where the report, when it comes back, and people don't know what it means. So we are helping them to create our own interpretation of that findings so that it's easier for clinicians to understand. And then we are also reanalyzing data, which means that if a child does not come back positive for a genetic diagnosis, we are looking at it ourselves. And then we are also looking at how it is going in terms of implementation and all these comprehensive implementation outcomes. So it's a teamwork. We are 3 PIs, myself, Tim Yu, and Meg Parker. And then we have other clinicians and informaticians and PhDs who are working with us to make sure that this project is successful. So we have so far enrolled 100 infants with the study, and a couple of papers have already come out, and we are working more on making sure we reach to the target goal of 250. But it is exciting to see how it is changing the care in some of these resource-poor NICUs. Moving on, I'm going to talk a little bit about what's the role of sequencing in healthy neonates. So far I've talked about NICU population, but more and more there is interest being brought up by the fact that maybe there is a role for sequencing in healthy neonates so that these diagnoses, which are later onset, can be picked up early and then treatments can be started sooner. So this is a statement from Francis Collins, who was the NIH director in 2014, who said that over the course of the next few decades, the availability of cheap and efficient DNA sequencing will lead to a medical landscape in which each baby's genome is sequenced, and the information is used to shape a lifetime of personalized strategies for disease prevention, detection, and treatment. So is this the crystal ball we have been waiting for? So we did a study, again, NIH-funded, called BabySeq. I don't know if you've heard of this study. This study was done between 2013 and 18, where we enrolled babies from both healthy side of things and also from the NICU, and we randomized them to either just standard of care versus sequencing, and in both groups. And what we found was that about 325, 159 were sequenced. 18 of them, there was some finding which was disclosed to the families. 4 of them, we could find something that explained the phenotype. But of 14 of them, which were supposedly healthy, we found 7 of them had a family history of disease. For example, 2 of them had titin mutations, which is associated with cardiomyopathy, and there was a family history of cardiomyopathy in those families. Similarly, BRCA1 or BRCA2, there were 2 families with BRCA2 mutations, which we found that on further exploring the family history, there were cases of breast cancer or ovarian cancer in the families. So this study was widely covered by the media. There was, as appropriately so, they said that baby DNA tests raise as many questions as answers. And then baby's genome identify risks overlooked by newborn screens. And deep dive into newborn's DNA may reveal potential disease risk. But is the testing worth it? So all these questions have been raised. After this study, there have been many studies that have been started now across the US, Europe, and other countries. These are some of the new studies that have come along and that are being done right now. After this study, there's a BabySeq2. There's Beacon NGS, the Early Check Guardian study in New York, Screen for Care, and then Genomics England and Screen Plus. So all these studies have been started on healthy newborns, looking at different sides of like some are based on panels, some are on whole genome. So we're going to see, next few years will be exciting to see what comes out of these studies. Moving on to research opportunities. So I told you we built a Menton Center for Orphan Disease Research, and these are some of the papers that we have published since we developed the centers. Every year we are publishing 2 to 4 new genes and papers on this new gene discovery, which are helping families, but also advance science and make it possible for families to get answers for what their child or their baby has. And lastly, I think this is a new horizon in terms of, can we really develop personalized therapies for these babies? So this is one example. This is a work that was done by my collaborator, Tim Yu, within the Menton Center, where they developed a drug specifically for a girl who was 7-year-old. Unfortunately, because she was diagnosed so late, her prognosis was not good. She did live for a few years, but sadly she died because I think the disease was so much advanced at the time of diagnosis. But it really shows the promise of, can we save these babies who are early in the diagnosis or who have a genetic condition, and can we develop specific treatments tailored to them? So this was done, this whole idea of developing treatment was done within a year, from referral to diagnosis to treatment. And this just shows the promise of what can be achieved. And I really hope that this is not just one-off case. There have been more cases that are coming out where personalized therapy have been developed, and that has helped patients. So my take-home ideas are that genomics is a vast area of clinical application and translational research. And I think that rapid exome or genome sequencing should be considered as the first tier test for infants with suspected genetic disorders. And all NICUs should have access to rapid genome sequencing. And I think that for screening, as a screening tool, we need more data, and that is already in order right now. And then research opportunities are huge in this area, and I think personalized therapy is the new frontier. And with that, I want to acknowledge my funding resources, the Genetic Mental Center Gene Discovery Core, my own laboratory, and the bigger team, which it is all how it takes a village. So I just want to acknowledge all the funding and the people who are part of our team who have made it possible. Thank you.